Hello. Good morning, everybody. Today we will discuss about the ACLS protocol for ICU nurses. And this presentation provides a simplified overview of the advanced cardiac life support, that is ACLS protocol for ICU nurses. It covers the essential steps to recognize, to manage, and treat cardiac emergencies in the critical care setting. Introduction to ACLS comes in 3 points. First, comprehensive emergency protocol. ACLS is a set of clinical intervention which is established by the American Heart Association, which we call as AHA, for the urgent management of cardiac arrest. By following saves lives. By following the ACLS algorithm, ICU nurses can improve patient outcome and increase the survival rates during cardiac crisis. Team approach, very important. ACLS emphasizes on effective communications and coordination among the entire healthcare team to provide high quality care. That is, ACLS emphasizes strongly that when you are resuscitating a patient, when you are using the ACLS protocol, in this during that time, should be a very healthy and good communications and coordination among the team, among yourself. Okay, when you give the medicine, when you give an adrenaline, you should tell it loudly, you speak it loudly. That is, it is given injection adrenaline 1 mg given, you should speak it loudly so that everybody knows that you have given these drugs, right? So that is very important. Effective communication among yourself improves ACL. Cardiac arrest recognitions and initial management. Recognize, quickly identify the signs of cardiac arrest, such as patient became unresponsive and there is no pulse, and also patient is not breathing or might be breathing abnormally like gasping. So immediately recognize cardiac arrest and initial steps: start CPR, high quality CPR, call for help, and prepare the defibrillator. If required, you need to give a shock. Again, effective team coordination, that is, ensure clear communication and assign specific roles to each team member to optimize the emergency response. That is, ask somebody to call um, and ask somebody to call up and declare code blue. Ask somebody to bring the crash trolley. So that should be an effective coordination among yourself, right? What are the rhythms we see in cardiac arrest? There are four rhythms we see. Mostly we see the asystole, that is a straight line. We also see pulseless electrical activity, that is PEA. We can see in the last ECG. These two ECGs, that is asystole and pulseless electrical activity, these are called non-shockable rhythms. That is, when the patient is having this rhythm in the monitor in the ECG, don't shock the patients. No need of giving shock. But on the other hand, shockable rhythms are when you see a VT, ventricular tachycardia, without a pulse, that is a shockable rhythms, or ventricular fibrillation, that is a shockable rhythm. So these two rhythms, that is a VF and VT, are shockable rhythms. Asystole, straight line, and pulseless activity, non-shockable rhythms, that is no need of giving. High quality CPR is very important. When you give CPR, give a strong compression at a rate of 100 to 120 per minute, and the depth should be around 2 to 2.5 inches or around 5 centimeter depth when you give a chest compression. Along with that, provide ventilation. Use an ambu bag and ventilate the patient at a ratio of 30:2. Okay, when you ventilate the patient, observe for chest rise, right? If the patient is intubated, no need of giving a no intubated, then there is no question of bag masking the patient. You have to ventilate the patients by using a bench circuit accordingly. It is important that when you are giving CPR to the patient, disconnect the patient. If the patient is on ventilator, disconnect the patient from ventilator and connect it to a bench circuit so that you can ventilate yourself, because because when there is uh, CPR, and when the patient is connected to a ventilator, then there is a lot of acid body. So when you take up the ventilation on yourself with a band circuit, then there will be good synchrony between the CPR and ventilations. And also you can also adjust the rate volume according to your choice. So When you give a CPR, disconnect the patient. If the patient is on ventilator, disconnect the patient from ventilator, use bed circuit for ventilation. And minimize interruptions. That is continuous, provides continuous CPR to the patients. If the patient is on ventilator, if the patient is already intubated, then continuously give CPR. Or minimize pause. If the patient is not intubated, then minimize pause to provide the ventilation. That is 30:2 ratio. Airway management, along with that, airway management is very important. If the patient is having tongue fall or there is an obstructive upper airway obstructions, you need to give an oropharyngeal or nasopharyngeal airway, and along with that, then we have to intubate the patient on the way. That is perform an endotracheal intubation to secure the airway and provide mechanical ventilations and ventilate the patients. So ventilate the patients, as I have already told, when you are giving a patient a CPR, it is better to ventilate the patient using bed circuit. Cardiac rhythm and identification and treatment. Shockable rhythms, as I have already told, shockable rhythms are VT and VF, that is ventricular tachycardia, ventricular fibrillation. Non-shockable rhythms are asystole and pulseless electrical activity. The medications, you give adrenaline or amigeron if required. And these are the drugs. This is epinephrine or adrenaline 1 mg every 3 to 5 minutes. Imiodaron 300 mg stat IV, then followed by 150 mg every 3 to 5 minutes. Lidocaine at the dose of 1 to 1.5 mg per kg, and then half the dose every 5 to 10 minutes, right? What is the algorithm? That is, see, when the patient is, when you have identified cardiac arrest, then immediately start CPR, connect to an oxygenation, connect to a monitor or defibrillator, and check the rhythm. If the rhythm is shockable, that is VF or VT, immediately give shock to the patient, 200 joules, right? Okay. So immediately give shock to the patient. That is biphasic shock. We generally have biphasic defibrillator, and 200 joules immediately give to the patient shock. And after that, give a CPR, continue for 2 minutes. Along with that, if there is no IVSS, start an IVSS. And after CPR, check the rhythm again. If after continuing for CPR for 2 minutes, check the rhythm again. If there is shockable, and again you have to give a shock. And after giving the shock, again start immediately the CPR. Along with that, give injection epinephrine 1 mg and intubate the patients. Advance have intubate the patients. If there is ETCO report, connect it to it. Continue CPR for 2 minutes. After 2 minutes, wait and check the rhythm. If again the rhythm is shockable, again start CPR. Along with that, also you can give drugs like amiodarone or lidocaine if required, and check for the for certain reversible causes. What are the reversible causes? We will discuss. These are the reversible causes. That is 5H and 5T. We will discuss, right? After giving CPR for 2 minutes, about giving drugs, after treating the reversible causes also, if the patient has not revived and the rhythm is still shockable, then you have to continue this cycle. But if the rhythm is non-shockable at any moment of time starting from here has become non-shockable, then stop giving shock. And then in that case, you have to go to, if the patient is not has not revived, that is no ROSC is attained, then you have to go to 10 or 11. Okay, but if the return of spontaneous circulation is attained, that is the patient has revived, in that case post cardiac arrest care is also very important. So what is 10 or 11? 10 or 11 is out there. So again, if so, we'll discuss. If the shockable rhythm is not shockable, that is, once we have discussed if the rhythm is shockable, then we give shock. But if the rhythm is non-shockable, no give shock. You have to start CPR immediately, and then you have to put an IVSS if not there, give adrenaline or epinephrine every 3 to 5 minutes and intubate the patients. After giving CPR for 2 minutes, check the rhythm. If the rhythm is shockable, then you have to give shock and continue this. Okay, but if the rhythm is not shockable again, then continue the CPR. And in the meantime, you have to think of the reversible causes. That is, these are the reversible causes. That is 5AH and 5T. That is, Reversible causes means that if you treat those causes, the patient might revive. That is, if the patient is severely hypovolemic, then give fluid. If the patient is hypoxic, you think because of that patient is having had cardiac arrest, connect to oxygenation, intubate the patients. If the patient is having acidosis, give soda bicarb. If the patient is having severe hypokalemia or hypokalemia, because of that it might be cardiac arrest, so you have to treat accordingly. If the patient is severely hypothermic, that also causes cardiac arrest, so you have to increase the temperature. That is, you have to apply a warm blanket or warmer, whatever, immediately. And if the patient, this is 5H and 5TR, if the patient has tension pneumothorax, then immediately give ICD. If the patient has cardiac tamponade, that is, immediately give pericardial drain. If the patient is, if you think it's because of certain toxins, immediately give the antidote, patient might revive. If it is because of pulmonary embolism, pulmonary thrombus, you have to might require to thrombolyze the patients immediately during the cardiac arrest, during the CPR algorithm. Along with that, if the patient you think is because of MI, active MI, then immediately give uh, mm, immediately thrombolyze the patient's IV, or you can go for PCI immediately, right? Okay, so treat reversible causes. Again, check the rhythm. If the rhythm is non-shockable, again it will continue like this, right? Okay. But if the rhythm is shockable, then this is the protocol we have to follow. Got it? Okay. So here the CPR quality is very important. That is how hard you are pushing. Push hard so that it goes a depth of around 5 centimeter or 2 inches, and push fast, that is around 100 to 120 per minute, and allow the chest to recoil. When you give a CPR, you should allow the chest to recoil. That is, it should come back to the original position when you give the CPR. And also minimize interruptions during CPR and avoid excessive ventilations. When you ventilate, don't ventilate excessively. Okay, and uh, when you ventilate, it is 30:2. When the patient is not having an advanced airway, that is 30 compressions and 2 ventilations. Okay, and along with that, if you have a capnography ETCO2 probe, connect to it and check it is to probe quantity wavefront capnography. If it is to probe is low or decreasing, reassess the CPR. Okay, shock energy, that is biphasic shock we use 1 to 100 joules we give. Drugs I have already told, I have already discussed. Advanced airway, endotracheal intubate the patients. Or very important to provide intubate the patients of, or you can provide in the supraglottic advanced airway also. Along with that, again capnography, check and to confirm and monitor the AT tube placement. And once advanced airway has been secured, then it is important to continue the CPR without interruptions, that is not 30:2, and ventilate at a rate of around 10 to 12 minutes, 12 per minute. That is around every 5 to 10 seconds you give, uh, every 5 to 10 seconds give one breath. There is no need of ventilating very fast to the patients, right? And once the ROSC has been attained, then you can check the, how you can check whether the ROSC has been attained. That is, while you are giving the CPR for 2 minutes. After that, when you check the rhythm, if the rhythm you can if seeing the rhythm you find it that the patient has the rhythm has patient has revived, and check for carotid pulse. If the pulse has come, that is patient ROSC has been attained. Okay, so that if you check the blood pressure, and if there is arterial line, you can check, you can also see the wavefront, okay, in the arterial monitor.